In Worcestershire, we need to save at least £60 million every year. What if AI could work in the background and save half of that? No, then we can actually concentrate on providing good levels of care to patients without trying to cut services, which, that's incredible, isn't it?
Morning. I'm Ian Hopkins. I head up the sales across Europe for Axonis. Joined this morning by two fantastic ladies that work in the primary care network here in the UK within the NHS. I'd like to start by getting both of you to introduce yourself.
Yeah, hi Ian. I'm Claire Goodhall. I'm the CEO of Vertis Health. We're the GP Federation in Worcestershire. I've worked in the NHS for 17 years, and all of that time I've worked in primary care in and around Worcestershire.
And I'm Katie Lowe. I'm Head of Operations at Vertis. Joined in 2020 through the COVID vaccination programme. Before that, worked for a long time in marketing, experiential events. It's a bit of a plot twist ending up in the NHS, but very proud to work in now.
AI in healthcare is a massive topic at the moment. It seems to be everywhere, at every conference. It seems to be in every article in the papers, across the news. What are you seeing in the primary care network landscape at the moment, and what's working for you guys today?
I was going to say that Katie's done most of the work that we've used in Vertis currently on AI. She's our tech whiz, and she's really good at AI. So she's the one who's leading the way for all of us in our senior management team. And from my perspective, being less operational, we're using it very much to make our processes more efficient. So these are not necessarily clinical processes from my perspective, non-operational sort of management type processes, such as writing policies and protocols for different services, and just utilising it really to, find the answers to questions more quickly and easily than we would be able to if we use Google on its own, for example.
And it's the kind of thing that we wouldn't want to be spending NHS money on. Obviously we want as much of our funding to go to clinical resource and clinical work as possible. So it's good for us to be able to find those opportunities to, automate workflows and, as Claire says, sort of get those SOPs and policies drafted so that, we've got a working draft. We're using it, across all of our departments. And, we've got some very good members of the senior management team who are quite, forward thinking with how they use it in the different departments.
That's cool. I mean, obviously the NHS is not abundant with cash, as you quite rightly pointed out. And so from what I'm hearing there, it's more around the operational elements of it, but those softer ones where it's looking at policy, governance, how you're adopting. How have you adopted AI into your sort of flows? Is there any specific sort of working examples or clear examples of where you've had benefits of it and where it's worked really well for you?
We've got a very small but very good data team. And when I say very small, it's 2 people. And it's only very recently 2 people. It's been one for a long, long time. And so Louis, who is our exceptionally talented data analyst, he does a lot of development work for us, to the point where we're considering, is analysts right? He's sort of sitting there on Power Apps all day doing all sorts of work. But because he's sort of, upskilling himself as he goes along, he's batting things back and forth with Claude and with ChatGPT, and he's sort of playing AIs off against each other a lot of the time to get to the right result, which is, an incredible use of the different technology. But using that to sort of upskill himself, test things out, and then go off and write the SOPs and policies to make sure they work, and, get the drafts of the governance documents. I mean, you can imagine, to get any sort of tech solution, off the ground, we need all of the sort of, DPIAs drafted, everything else like that. So for him to be able to come to me and present me with all of the governance drafted, all of the, the frameworks, all of testing, all of that sort of system architecture as one person is an incredible, incredible achievement. And he wouldn't have been able to do it on his own. And, certainly without that support. And I don't mean that to minimize him being a very talented person. But what I mean is just in terms of hours in the day, he would not have been able to do that without the support of AI.
I also think that there isn't very much on the market. There's no real kind of like off the shelf example of a platform that we can use to workflow in our kind of environment. So he's actually just started to produce something that will workflow our tasks for people as well, which is just incredible. It's something that I'm used to from my previous experience of banking, and Kate has probably utilised workflow platforms in her other jobs as well. But to the best of my knowledge, there's never been anything available in primary care to be able to do that for us. We've managed to switch from using emails as our main source of workflow into a sort of custom-made platform, which I think is absolutely incredible. And I think 5 years ago, we would never have been able to do that either.
Agreed. And I guess that every member of the primary care network has their own nuances as well. So what works for somebody else might not work for you because of the way that you approach stuff. There are going to be nuances in the way that you deliver your services across county. We touched previously in previous conversations around your example around ADHD. We had a couple of examples there, both in adult care and with obviously child services, paediatric care as well. How has AI impacted around those services?
Well, we did a pilot of an AI scribe in the adult ADHD service, and that was sort of mixed results in terms of how it worked, but definitely successful enough for us to want to continue it. So as an example, our adult ADHD assessments, we managed to reduce the assessment time down from 3 hours to 2.5 hours across the board, because it was sort of scribing for the clinician. So previously the clinician would be sitting there typing away, sort of making those notes. So it'd be a case of clinician asks the question, patient answers, clinician writes it down as they go. And obviously that's most people's experience of, any kind of healthcare appointment. What this allowed them to do instead was sort of have a more free-ranging conversation with the patient. And in the background, the scribe is sort of making notes on that, and then it fills it back into the template questions that we would have wanted them to ask. So the clinician can still be referring to our template, but they don't necessarily have to ask the questions in the same order. They can kind of follow the flow of the conversation. And for patients with ADHD in particular, that works really well, because obviously you can imagine, the sort of nature of ADHD is that it's more of a sort of a conversation that goes sort of various different places, and it sort of supports the patients a bit better to do that. So that was really, really, really positive for patients. There were some legals on it. The software that we used didn't integrate with our existing clinical software, which we use ENIS. So because it didn't integrate directly, we still had to have the clinicians then copy and paste the results from the AI software into EMIS afterwards. So we didn't completely eliminate the admin time, which was kind of the goal of the pilot. If we could get to that point, I think we could reduce the assessment time even more. But I think there's certainly a huge amount of scope for it. And just by what we did, we managed to pay for, that sort of reduction of 3 hours to 2.5 hours, pays for the AI to be implemented. So it certainly, delivers value for money. And patients, I think in terms of patient experience, it's a definite improvement, because clinicians can sort of be looking at the eye in the same way that we are now. So it's definitely an improvement.
And I think from a general practice point of view, many years ago, there was dictation software available, and that didn't really take off because I think it was so poor at understanding people's accents and language, etc., that it actually didn't save people that much time, and only the most technical GPs would have actually continued to use something like that. So, the difference now in the last 10 years is incredible, the way that the AI can actually understand you and interpret what you're saying in a way that kind of scribe software never could in previous years.
It's definitely far more intuitive. I just want to pick up on a couple of the points you've made there, because I think there's some really clear examples there of ROI and the benefits that you'll probably receive. And that short reduction in time of half an hour in that clinical setting, in that appointment time, there must be significant other benefits that you're reaping from that.
So with the adult service, we would work on the assumption that obviously the EMIS notes go into the NHS app, and so therefore the NHS app is available for the patient, and so we don't necessarily send them a letter. But we got feedback from patients that actually they would prefer to have a letter, because they can use that as evidence of their diagnosis in sort of various different settings. And we sort of wrangled with, well, it's not in the budget, that clinical time, and we're running on, a fairly tight budget anyway, because, obviously these things always are. So how do we fit that in? And then obviously when we added in the scribe, it was easy enough for us to say we can click a button and it can generate a letter as well. So it's an additional benefit to the patients. In the children's service, we've been sort of able to take that a step further, because what we can do is have it generate different letters for different audiences, which I think is a really nice benefit to patients. So as an example, so the children's services are children's ADHD, children's ASD. So if you're a child or a parent of a child with one of those conditions, it's really beneficial for you to have a letter, outlining the child's condition. It's even more beneficial for you to have a letter that's tailored specifically to the school. And it's even more beneficial for you to have a letter that explains it at the age level that your child would benefit from. Because actually that kind of gives the parents language to speak to, it sort of helps the child. And we have that feedback from, I think it was one of our local autism co-production partners. that was the most difficult thing, from getting a diagnosis as a child. It's understanding it, because reading the sort of adult level clinical report can be quite sort of traumatizing in its own way, and actually getting that in that sort of appropriate language is brilliant. So that's something I would sort of training the AI to write that at those different age levels to support. And I think that'll be a really, really brilliant benefit.
I think you're right. I think that sort of understanding and the ability to understand their own sort of diagnosis and condition from an early age really empowers them, I think, longer term. On the subject of patients, obviously AI, various things in the press about it being scary, hallucinating, going off and doing different things, booking holidays for people, whatever in the background. How is it being perceived by your patients? Is it something that's scary? Are they willing to sort of adopt it and take it on board? People just nonchalant, don't really care? What's the sort of the view from the patients that you're kind of seeing when they come into your clinics?
I think we sort of mentioned in previous conversations that a few years ago, when the NHS app was being developed, patients that they received a letter from the NHS about sharing their data. And there was some concern a few years ago that data would be shared in an inappropriate way, and you had to have the opportunity to opt out of sharing your data with various other places, people who might be involved in your care. I don't think we've seen anything like that recently when we've been talking to patients, and I guess AI is building on the back of that. There's an expectation from patients that we can do more and that we can give them more because of the advances in technology. Katie does feedback loops on every service that we provide, so people do have the opportunity to feedback.
Yeah, it was really interesting. It was the feedback we stopped getting that I think was really interesting, because we went from, people would quite often say it felt like they were being run through a questionnaire during the assessment, which makes sense, because obviously to an extent they are. The clinician has got certain questions that they have to answer in order to decide whether they're getting a diagnosis of ADHD or not, which, that is clinically appropriate for them to be asking those questions. But obviously for some clinicians, they are, it's just the way that they're doing is they're quite methodical. So they are asking these questions one by one. And I think because they want to make sure that they've answered everything, they are, because they're conscious that they've got to type it down, they are sort of doing that quite step by step. So, we understand why we're getting that feedback from patients. But when we were doing the pilot, we noticed those bits of feedback dropped off. And I think it was because the clinicians were able to be a little bit more natural in the way that they were, the way they were posing the questions.
Demands on your service at the moment are probably pretty high. I think everyone's trying to fight to get appointments and everything else. Demand across the whole of, I think, society at the moment and public sector is a 24/7 approach. People are wanting access on their own terms and their own times.
Yeah, I think that obviously at the moment patients are quite used to having to telephone their surgery for an appointment, and they have to normally go through some kind of triage. So they would normally phone up, they'd say they want an appointment. There's normally some kind of IVR telephone response where they have to choose the correct option. Quite often now GP practices are asking patients to complete an online consultation form. So they don't even want to phone the surgery. And then you wait for your phone call back. And I suppose you don't really know what's happening in between the 2 points. You've sent off your email with your consultation request, and then you wait for a phone call. I think personally that we could use AI to improve that service to patients in respect of, could we get AI to do some of that triage process so that patients could actually get some answers for very minor illness immediately?
I guess it's about being heard as well, isn't it? About being sort of managing their expectations as well, but being heard initially. And then, like you said, assigning the appropriate resources to it. Does it need a full GP consultation, or could somebody else pick it up?
Yeah, I mean, I think one of the areas that we sort of think quite a lot about is how we can make the patient pathway more streamlined. Obviously I'm ops, so of course I'm thinking about that. But something that we've been working on a little bit in the background is sort of RPA. At the moment, we're not at a stage where we'd be confident enough to hand over too much real patients facing bits and bobs to an AI. But the bits around decision making around sending text messages, and when I say decision making, I just mean the sort of the gate of yes or no. Is it time to send a text message? Yes. Those bits and bobs, which are traditionally done by a member of my admin team, for instance. It's not fulfilling work for my admin team. God bless them. They've got a million other things to do. And so hitting that button sort of 20 times is not the best use of their time. But it probably is a good use of an AI. And it's low risk. So those are areas where we're thinking, okay, that's probably a good area to roll it out. Whereas the sort of, anything that touches sort of clinical decision making at this point, we'd be fairly risk averse to have the AI chat to our clinicians and give them advice on their patients, which in theory sounds amazing, and it probably is amazing. But just during the 4-week pilot, we just felt that might be just pushing it a little bit too far before we've done all of the governance, because I think that's, for us, probably just slightly ambitious initially. But obviously, I can't imagine it would be long before we'd feel confident.
That sounds good. It sounds like a strong use of it. We touched on the patient experience. Has either of you experienced the use of AI in a GP environment at all, and had a positive or negative sort of opinion of how it's worked for you?
Yeah, I did. And it did actually change my opinion slightly, because Claire and I had a conversation about when we were scoping out the use of AI in our ADHD service. And I'd said I didn't really see the use for it in general practice, because I thought all the notes would be so short and there wouldn't be any value. So I slightly ate my words on that. I had to pop in for an appointment. It was sort of picking up on it. So typical me. I'd not been into the GP for about 18 months about something I needed to get sorted. So I did have to explain quite a lot of sort of background. But I noticed when I was walking in that they were using a different scribe software to us, but, an AI scribe, and they sort of advertised it very well. They said, we're trialing the use of whatever it is. And it was a very good GP appointment in that the doctor I was speaking to wasn't having to type at all. She was able to have it much more like a conversation, very, very thorough. And then afterwards I came out and, my NHS app straight away, really detailed notes, full sentences, not like, God bless our GPs. I know they're busy, but it's sort of very much a sort of short notes that they're going to get the next patient in ASAP. This was much more like a sort of thorough, sort of here's what we discussed today. And it did make me think, there's definitely scope for it in general practice.
Yeah, absolutely. And I think also, there is, for the last few years, at least for the last 5 years, we've been talking about segmentation of primary care. So, could we find some way of dealing with urgent care so that doctors could have more proactive focus with people with long-term conditions? So rather than having a 10-minute conversation with somebody about some minor illness, we have much more proactive, maybe like half an hour appointments 2 or 3 times a year with those people who are most frail, most unwell in our surgeries, taking time to speak to them in a really collaborative way, coming up with care plans. We're reviewing medication. We're doing everything, really like a holistic consultation with people. And in those scenarios, you can imagine that AI would be incredibly helpful, not just because of what Kate has just described as in terms of, being able to focus on somebody, give them your attention, not be distracted by trying to type, but also in terms of the accuracy of the notes, because, you can discuss quite a lot in a half an hour at a consultation. So actually remembering to type all of that up and the facts right, that's a challenge in itself. So I think for those longer appointments that are more focused on care planning, I think it would be invaluable.
I guess it leads into another question that's just come to mind, is that sort of transition between primary and secondary care and emergency services. What's the view from primary care looking at the wider sort of network of the NHS?
Yeah, I think within a hospital, you can have many different types of software to support that particular area. And some notes are still held on paper in hospitals. But we've really struggled with integration. We in Worcestershire have got community services of one different company. Then we've got the acute trust, secondary care is a different company. Primary care, there's 60 odd independent providers in general practice. And we're lucky that we all use EMIS, but the integration between all of our systems has been really difficult. Even if somebody goes into A&E, it can take quite a long time for a discharge summary to come from A&E into a GP practice, when ideally you'd want it the same day or, within sort of 12 hours of that person being seen. That just doesn't happen consistently. So I think there is a long way to go with integration of those, that information. I think patients should be the owner of their own data and their own medical records, and that should be able to be shared with whichever part of the system that they're approaching for that piece of care that they need at that point in time. The NHS app doesn't go that far. It hasn't actually achieved that, although I think the promise was there originally. Obviously, that has cost billions of pounds, and at least we've got something now that we can carry around on our phones. But it's not good enough. It doesn't give the detail that we would necessarily need.
I guess it would be a permissions-based type rule, wouldn't it, for the NHS app, that you walk into a facility and you can share it with them immediately to access your record. Maybe they don't, as a patient, you can't read your record on the app, but it's there, you can see it in its entirety, but you can share it quite quickly. What's the utopia for the NHS in your opinion, both from an operational perspective and as a CEO's lens? What should the NHS be doing with AI?
Right, yeah, it is a big question. I mean, I think a lot of it does come back to this integration piece. I think for patients to be able to sort of get the information that they want, but also through a sort of really well integrated system, and I think AI could certainly enable a lot of that. As Claire says, with the systems not being able to talk to each other, it does mean that there's all these sort of bumps in the road for patients. And a lot of the time, I think as ops people within different organizations, we're sort of trying really hard to work together to sort of untangle these knots. But a lot of the time it's technical issues that we can't resolve. And I think if we could get over those things, I think we've got a lot of people who really want to work together but can't. If we could get the tech to sort of enable that, I think the patients would have a much more seamless journey. It probably helps people get the care they need faster.
And I suppose the other thing is data, isn't it? So, Katie, again, loves data. I'm less so, but I understand the importance of it in terms of more like triangulation of the data from each of the different parts of the system. So, trying to be able to identify what we need to invest money in as a system, where we need to focus our care. So if we can triangulate data around, urgent and emergency care, for example, why are people going and using our A&E departments? What's their background? Is there a trend there? What could we have done differently up front to mean that they could have had some proactive care that cost less, that meant that they didn't have to have a crisis?
Yeah, I think that's probably the NHS is a fantastic institution that does have a retrospective view on a lot of stuff in terms of care delivery. And obviously the 10-year strategy is focusing on more preventative, using digital to be more preventative. Do you think it's going to have a big sort of shift within the way that the care is being delivered across the NHS?
I think it's going to be really hard from a clinical perspective to use AI more. I think there's going to be a requirement for so much testing, and there's going to be, clinicians are going to probably put up some barriers because they will be uncertain of the accuracy. If we can integrate it into the sort of back office operations, I think that will give us time then to make some of the efficiencies that we need. I mean, we always, in Worcestershire, we need to save at least £60 million every year. We're always overspent by at least £60 million. I mean, what if AI could work in the background in our back office kind of situations and save half of that? Then we can actually concentrate on providing good levels of care to patients without trying to cut services, which, that's incredible, isn't it? That would be a fantastic outcome.
I think we're in a good place where we could potentially lead the way on some of this stuff and sort of then, talk to other organisations about how we did it. So that's, a nice place for us to be, I think.
There's a great segue, because my next question is going to be around governance and around sort of adoption. There's always going to be early adopters for every piece of technology. Orthopedics has had AI-assisted surgery now for a number of years and has been using that to the benefit of patients. You've obviously got an organisation full of clinicians, so some will adopt early, some won't. How do you manage that challenge? And then how do you manage the governance around them utilising it?
I mean, our policy that we drafted it earlier this year, and it was triggered by a conversation that we had around smart classes, because it occurred to us that, let's say, a healthcare assistant or a nurse got given some meta classes for their birthday or Christmas or whatever, and walked into their clinic and logged into EMIS. That would be an enormous potential breach of GDPR. It'd be a nightmare. And I think it's that background risk that I think we just need to be really mindful of now. We have got people in the organisation who are really, really switched on to AI. but might potentially push the boundaries a little bit too far, you know, in a well-intentioned way, you know. So they might be sort of thinking, I know, what if I just did this? What if I put this into ChatGPT to trying to innovate? But obviously, because we work with such sensitive data, we as an organization just need to go, this you can do and this you can't, and just be really clear with people about what that, you know, where those boundaries are. But also leave the door open for those people who've got really good ideas to come to us and say, actually, what if we did this? Because you never know where that next brilliant idea is going to come from.
Are you concerned about the potential hidden cost and the looming invoices that come up with the use of agents and tokens and tokenization across the market?
To the horror of our finance director, we've been trying to get the balance right between return on investment that we can actually calculate in monetary terms, and actually also that kind of added level of patient experience and quality that we might be able to achieve by spending a little bit more. So it is all about balance.
100%. I think you've got to obviously look what's right for your organisation and then balance it out. Those softer benefits that the patients and clinician will see sometimes can't be quantified. So it's hard for a CFO to look at it on a piece of paper and go, yeah, that works perfectly, because you can't measure those. So, I mean, one last question I've got for you is, what should healthcare leaders take away from this? Where, if you had a moment with the powers that be at the top of the Department of Health and Social Care, what should be the big focuses for them, or where should they be pushing with this?
I think there's got to be, we need some leadership around governance, don't we? So, I mean, that's probably our biggest fear, our biggest risk is, you know, could we unintentionally breach something, and, you know, how are they going to protect us against that? And, you know, we would never knowingly do anything, but we don't know what the potentials of AI are.
I think, you know, from a leadership perspective, it's really easy to say we've got a great idea and we're going to roll this out to everybody and you've got no choice but to come down. But actually, I think that can make people really defensive about new technology, and, you know, it can really put them off. And I can understand why people have got, you know, a certain amount of resistance to AI, you know, because of all the concerns that Claire's just had. So I think it's that sensitivity to where people are. You know, I think there's good reason to be sort of cautiously optimistic about it. But, you know, just sort of bringing people on the journey, I think, is really important.
Thank you both for your time today. It's obviously a broad subject to cover, AI in healthcare, but I really appreciate you taking the time out of joining us today. I wish you well in your journey with AI.